plasma chemotherapy or anti-cancer therapy. It's the last recorded one, and starting from next week, I'll be seeing you in person. Okay. Now, this is only an introductory lecture. Up and then we'll focus on the principles of chemotherapy. Okay. So before we start, it's always good to have a historical overview about any drug, حتى you appreciate how fast, especially these days, how fast things are changing. So for cancer itself, it was recorded as old as in the ancient Egyptians and بالفراعنة. They found a written description of the disease, especially a case in breast cancer. And then also ancient Greek, they also realized the cancer as a disease, and Hippocrates called it carcinoma. Okay, and carcinoma in the Greek word it means crab. It means هذا الحيوان سلطعان. And this is because when they to capture its invasive feature, okay, so Hippocrates thought it will إنه بيكون invasive, so it's the tumor cells will grow into the surrounding tissues, and Hippocrates thought it looks like a crab, so it's called it carcinoma. Now the Roman translate carcinoma into cancer, and this is why we use the cancer. So it's cancer is the Roman word for crab, and and as early as in the Roman era, and this was 25 year BC. They described the treatment of cancer by surgery. So surgical removal of tumor dated back to this really old era. Now, with more sophisticated tools and especially with the discovery of the X-rays in the 18th century by Wilhelm Röntgen. This helped in the cancer diagnosis and treatment, and after that came Marie Curie and Pierre Curie, and they discovered the radium and polonium, which paved the way for radiation therapy. Now, in the early 20th century, especially in the 50s, now the DNA, the structure of the DNA as a double helix was established, and really this founded the understanding of the genetic and inheritance of variation in cancer. So cancer now is looked انتوا راح تاخذوها او راح تاخذوها بالباثولوجي is really a genetic disease. It's kind of a genetic, there is a genetic abnormalities, accumulation of mutation, and this is the foundation of cancer development. So, and then in the late 90s and in the early 21st century, there was a project, a huge project, a multi-center where more than one country involved. It's called the Human Genome Project. In this project, هذول الانستيتيوت, they could identify for the first time the human genome sequence. And back then, the technology, it's a huge lab and a lot of work and a lot of collaboration to do this. Nowadays, human genome sequencing or genome sequencing is really fast and it's much easier and cheaper than before, but it was back then it was a breakthrough, because now studying the genetic of human genetic and cancer genetics really paved the way for different drug modality, including targeted therapies, which was first developed in the 2000s, and also immunotherapy. And with the continuing advancement, the cell-based and genetic therapy. So all of these are, you can read them, and you can go to this website and see more if you want to. يعني هيك if you're interested وعندك فضول تشوف the history of cancer. It's really a nice overview. So, why everyone is talking about cancer? Why cancer is important? Because it is a widespread, disease, and there is something called cancer burden. It's how much people are affected, how much the economy is affected, the health sector is affected, and it's and it's ongoing problem, especially بالعالمنا, in Asia and in the developing countries. So it is predicted that by 2050, more than 35 million cases, new cancer cases will be added. So it is a lot. It's a lot of cases, especially in our area. So there is a high cancer burden globally. And also cancer, for example, is a leading cause of death, for example, in the US. And in the US, every year there is 1.6 new cancer patient diagnosed. And the overall 5-year survival of cancer is about 68%. So يعني من هذول ال 1.6 million, يعني أكثر من 30% will die within 5 years. Okay, so this is a huge burden on the health sector, on the patient themselves as well. So how does يعني ما بعرف انتوا وين وصلتوا بالpathology. You should cover this in pathology, but we will have just هيك يعني زي a glance about how cancer is developed. كيف بصير عندنا الكانسر بالجسم. حتى we can discuss therapeutic use, والmechanism of action. You have to understand how cancer develop, or have a شوي idea قبل ما we discuss chemotherapy drug treatment of cancer. So cancer happens when لما يصير عندنا accumulation of mutation. So it starts with the normal cells that accumulate mutation and transferred into a malignant cell. Okay. These malignant cells they gain properties enable their uncontrolled proliferation and يعني نموهم. Okay. Now the hallmark of cancer, it's لما تسمع انت the hallmarks of cancer, the hallmarks of cystic fibrosis, or the hallmark of a certain disease, it's what is the characteristics of that disease. Okay, so Hanana and Weinberg بالريفيو تبعتهم they developed a framework to show how normal cells transform into malignant cells. And later on we will see why this is important, especially in the era of targeted therapy, why it's important to understand all these pathways. So just forget this outer layer, and if you focus here on the inside of the circle, you'll see this is the tumor and the tumor microenvironment. You will find here, for example, different type of cells. And this is in solid tumors. In solid tumors يعني احنا عندنا tumors بالblood tumor وعندنا solid tumor يعني leukemia مثلا they're blood tumor. وsolid tumor مثلا lung tumor أو colorectal tumor. These are called solid tumor. So tumors usually have different type of cells. Some of them are cancerous, some of them non-cancerous. And this is what we call heterogeneity of the tumor. And this we call, you will hear about microenvironment of the tumor. So this is a tumor with different type of cells. Even the cancerous cells themselves will have different genetic abnormalities. And you have even normal cells that also may support the growth. يعني tumor cells will exploit these cells, normal cells exploit their growth more. Okay. And here in the outer circles, these are the pathways or characteristics, hallmarks of uh, genesis of cancer, how cancer is developed. So, for example, if you say here, these cancer cells will gain mutation that make them evade growth suppression. So الجسم عندنا بحب يعني it's very controlled. الgrowth تبعه, cell growth, organ growth, whatever growth is very controlled. It cannot, after a certain مثلا size it's and shape, it should be stopped. However, and it should be stopped, and الجسم is very organized in stopping and killing any this extra cells that's trying to make an abnormal growth. However, cancer cells somehow evade these growth suppression. Okay, they can also avoid the immune destruction. So it's the body itself, probably into أخذتوها بالgenetics, when there is accumulation of, for example, DNA and a new epitopes appear on the cells, this will be detected by the immune cells and it will be destructed. So immune cells بالbody, it will make a surveillance بتمشي بالbody. Any cancer cells or any cells with abnormal cell, it will recognize it and destroy it. Again, cancer, it's to develop to the disease, it will avoid this, somehow avoid the immune recognition and avoid the immune destruction. For for an example, induced angiogenesis. Angiogenesis is the building of new blood vessels. So the cancer, it's growing, it needs more oxygen, more nutrients. So شو بيسوي? It makes a new blood vessels. See here, it makes a new blood vessels to get more nutrients to meet the high demand of this fast growing cells. You can here see how hallmarks of it. Also, for example, resisting cell death. So again, لما يصير عندنا أخذتوها أنتوا أكيد بالجينيتك اللي هو DNA repair, if there is immuno checkpoint بالcell cycles. إذا كان عندنا مثلا السيل DNA replication تبع chromosome replication, for example, if there is a mutation, accumulation of mutation beyond repair, then the cell, it will signals its programmed programmed cell death or apoptosis to يعني تقتل هاي الcells with beyond repair DNA. So again, somehow this cancerous cells with plenty of these accumulation of mutation also evade the cell death. So all of these you can see here, and probably انت رح تاخذوها بالpathology, أخذتوها بالgenetics. All of these are pathways that can be targeted by a drug. And here you can see here all these are drugs important for the targeted, we will see later, conventional chemotherapy versus targeted therapy. Targeted therapy involves targeting, رح نحكي عنه بعدين، إنه هذا الدرug it will target a pathway بالcancer cells that is يعني unique للcancer cells and try to only destroy cancer cells. This is why it's important to understand the hallmarks of cancer or the pathways that makes this make cancer itself. So again, cancer chemo. We will talk about the here, and for the next two lectures, we'll talk about more about the conventional chemotherapy. So الانتي-cancer احنا حكينا المرة الماضية عن we do have plenty of drug modalities, small molecule, RNA based or oligonucleotide based drugs, protein based drugs, monoclonal antibodies, for example. And so the anti-cancer drug modality we will have, it's the conventional cytotoxic chemotherapy, which is the oldest خلينا نحكي modality of uh, drug, anti-cancer drug. These cytotoxic chemotherapy من اسمهم, they exert their effect because they are toxic, يعني سامين للخلايا. And we will talk more about their يعني in general how they work. بس بشكل عام they work because the cancer cells, they are rapidly growing more than in normal cells, so they exploit this feature of cancer, and this is why they attack the cancer and try to kill it more than, for example, the normal cell. Even they will have many side effects because they will also have negative effects in normal cells, but the idea is that they are more toxic to the fast growing cancer cells. Also, we have hormonal therapy. We're not going to talk about hormonal therapy, but just to know there are a lot of drug modalities and you will hear about them probably later. So hormonal therapy is for cancers who are hormone sensitive. For example, breast cancer, prostate cancer. Many of these therapy, they will block the receptors of the hormone. So many of these hormones, for example, testosterone is important for for prostate cancer to grow. So when you suppress this receptors, suppress the act of testosterone, the prostate cancer will not grow more. This is in a nutshell, okay? We also have targeted therapy. We will talk about targeted therapy and immunotherapy in the last lecture of the chemotherapy, so on Thursday, inshallah. And they include kinase inhibitor, monoclonal antibodies. So again, targeted therapy, they benefit from our understanding of the unique pathways that led to cancer development. And then immunotherapy, the immunotherapy is it enhances the immune system to kill the cancer cells, including immune checkpoint inhibitor, the cell-based treatment, for example, CAR T cells, where they take the T cells from the body of the يعني من البيشنت and they teach T cells to kill tumor cells and then put it back in the patient to fight the cancer. And as well as there is cancer vaccines. Some of these cancer vaccines are prophylactic. For example, the vaccine of papillomavirus vaccine to prevent cervical cancer, and some of them as well therapeutics. There are vaccines, for example, for lung cancer. Okay, they also try to help the immune system to recognize and fight cancer. Now, just have a quick historical overview of the chemotherapy itself. So the word chemotherapy is not new to you. You heard it first probably when you talked about the antibiotic. So Paul Ehrlich is a German microbiologist, I think. He's called the father of chemotherapy. He coined the term of magic bullet and chemotherapy. So you know how in the term chemotherapy is that the idea is that you can synthesize or chemically target the organism or by chemical or by what's called selective toxicity. So this drug will target the disease, for example, the bacteria or the cancer, and not the normal cell. Okay. and this is what's called target selective toxicity. Then in the 1940s, where and during the World War II, people يعني بالهذا استخدموا الماسترد غاز، الأسلحة الكيميائية، they started scientists شافوا إنه this mustard especially mustard nitrogen gas, it was used in the chemical warfare. It started to have positive effect on lymphomas. So Gilman and Goodman, they started to investigate this nitrogen gas to treat lymphoma. Then came Sidney Farber, which is called the father of modern chemotherapy. He discovered aminopterin, and aminopterin was the first successful drug to cure childhood leukemia. So if you remember, we said that surgery and chemotherapy surgery and radiation started before the chemotherapy. So the idea is that, for example, before the chemotherapy, let's say you have a solid tumor, and the surgeon can dissect this tumor. However, how can you treat leukemia? How can you you can't, there is no solid, there is ما في mass السيرجن يشيلها، مو صحيح؟ أو ما في mass السيرجن تارجت الكيموثيرابي عليها. فإت was a huge breakthrough لما إنه هو عالج اللوكيميا because it's يعني ما كان لها حل. اللوكيميا أبدا ما كان لها حل، لأنه back then they more relied على surgery, removal of solid tumors. So that was هذا فاربر، وهذا هو Paul Ehrlich. So that was a breakthrough. Okay, however, there was يعني relapse, but at least there was hope for those patients. After that, the scientist community started to note يعني مع الكيموثيرابي advancement there was يعني شافوا في أهمية إنه أوكي صار في specialties, and in 1973 the program of medical oncology was established as a clinical field. يعني أنت تقدر هسه تتخصص يصير اسمك oncologist. اوكي before 73 ما كان في الميديكال oncologist. Okay, and so الكيموثيرابي started يعني use of chemotherapy صار أكثر وأكثر بدل من السيرجري أو مع السيرجري. So now most patient receive chemotherapy, and only a quarter of these patients will be cured only by surgery. So chemotherapy now is a huge, يعني a lot of patients, cancer patients, most of the cancer will receive chemotherapy. Okay, how does chemotherapy, conventional chemotherapy, cytotoxic drugs works? Okay, so من اسمها cytotoxic, it kills the cells. So chemotherapy triggers cell death أو إنه it arrest الgrowth تبع الtumor. And this is through apoptosis and non-apoptotic death. So الخلية, there are different types of death, of cell death. Okay, المور رح نحكي organized and يعني اللي هو الابوبتوسيس. بالابوبتوس يعني I'm sure you took it أنا ما رح أحكي عنها كثير لأنه يعني out of the scope، بس you will hear a lot about the apoptosis or non-apoptotic death بالchemotherapy. بس يعني you should have taken this بالpathology بالgenetic whatever يعني. بس apoptosis, as you probably know, it's a more programmed clean death. There's no inflammation. It's يصير عندنا condensation بالchromosomes, and then fragmentation of the cells. It's a clean death of the cell. There are other types of death. For example, necrosis. Necrosis is not clean. Necrosis is في عندنا مثلا after injury، في عندنا inflammation، في عندنا collateral damage to other cells, so it's not as clean as apoptosis. However, chemotherapy may trigger this necrosis. Autophagy. الأوتوفاجي هم هاي لاحظوها إنه it's another type of programmed cell death. بس هنا it has a different feature. أول إشي الخلية بتصير يعني زي تاكل أو it enclose its organelles عشان it's probably عشان recycle النيوترينت وميكس، يعني لما يصير في ستريس على السيل بيصير في عندنا inclusion for example Golgi apparatus وللأورجانيلز نفسها تبعت والسيتوبلازم تبع السيلز to recycle these things. And then it may lead eventually to death, cell death. We have also mitotic catastrophe, whereas the الميتوsis is when the cell is replicating and separating, and هون بيكون في dysregulation of the chromosome alignment and separation. This is which make يعني under the microscope you may see different cells with probably more than one nucleus, which lead eventually to the death of the cell. And finally, senescence. Senescence is when the cell stop growing. Okay, so you know how the cell goes into cell cycle and then replication of the cell. Senescence is when goes and we say G0. The cells are arrested in the G0, G1 phase, so they're not growing anymore. Okay. هو المفروض يكون recorded بس it's okay if someone get in. Now السلكتيفيتي of الفكرة إنه مثل ما حكى إيرليك إنه selective toxicity, and you hear this probably قبل بالantibiotic how selective toxicity it is. But بالconventional chemotherapy its targets الselectivity تبعتها selectivity بين قوسين. It's because the tumor cells are يعني is rapidly and يعني dividing, and so tumors are more sensitive للchemo, the cytotoxicity of the chemotherapy than normal cells. However, the chemotherapy it's not selective at all, and the normal cells especially الابيثيليال مثلا الابيثيليal cell of skins, they're growing يعني every day, and they have replication تبعتهم نسبيا عالية, but they will be affected by the chemotherapy. However, الchemotherapy the selectivity تبعتها ideally it's only التارجت تبعها is only found in cancer cells. Okay, so normal cells will not be affected, or the target can be similar but not identical to normal cells, or it's overreactive in cancer cells, which is the last one is what we see more with the chemotherapy, cytotoxic chemotherapy. These two probably more in targeted therapy, but overreactive in cancer cell, you will see it in conventional. It's where it's because it's growing fast. كل pathways تبعتها overreactive, so it's more sensitive to chemotherapy. So as we said, chemotherapy they will attack fast growing cells. If you remember من الجينيتكس إنه الcell cycle of the gel of the cells في عنا الميتوتيك في هاي الميتوسيس، بس قبلها مثلا بالجي 1 اللي هو ال synthesis of cellular component needed for DNA synthesis. So there are distinct phases of the cell cycle before the mitosis and before its replicate. عندنا G1 وين بزيد عندنا ال component of the cellular عشان in propagation of replication, and then the S phase when هون ال DNA synthesis, ال G2 synthesis of cellular component for mitosis, and then again it will enter the mitotic phase where it will يعني replicate and with daughter cell separate. Okay, so these are a distinctive phases بالcell cycle. So in مثلا نحكي هذول ال 40% 39% 19%, those in average, and it's different from one cell type to another, but let's say 40% of these of the cell, most 40% of the time or 40% of the cell will be in G1. Same تقريبا then of the time 40% almost 40% of the time it will require DNA synthesis, and mitosis is actually only is fast, is considered fast. It's 2% of the time. So however, sometimes this G0, it's the cells, this is where we talked about senescence, where it's the growth of the cell is arrested in G0. So it's not replicating, it's after mitosis, it keeps the same يعني size, the same component, it's in the G0 phase. Now, the tumor susceptibility chemotherapy depends on how much of these cells are replicating, or how fast are replicating, or how much of the يعني الtumor have, how much fraction of the tumor is in this cycling period. Okay. So the growth fraction influences tumor susceptibility to most chemotherapeutic agent. The growth rate of most solid tumor is initially rapid, يعني so solid tumor عادة الجروث تبعها بيكون سريع. بعدين it decreases as the tumor size increases. And this is because يعني لما يزيد السايز النيوترينت ديماند، الاكسجين ديماند كلها بتزيد، يعني انت فالتيومر لانه في نقص نيوترينت ونقص يعني اكسجين، growth rate will decrease. Okay, this is in most solid tumors. The blood tumors usually are more يعني خلينا نحكي الريت تبعهم عالي. A lot of them, a lot of growth تبع أو a lot of these blood cells are in the cycling, and this enters the cell cycle and it's fast. So again, neoplasm with high percentage of proliferation are more susceptible to something called cell cycle specific therapy. So the chemotherapy are either cell cycle specific or non-cell cycle specific. The tumors with a high percentage of proliferation rate are more susceptible to cell cycle specific therapy. Okay, so some drugs will, for example, work on G2 or G1 or on the S phase, or even in the mitotic phase. For example, any cells that is in its of the tumor, it's in its mitotic phase, it will be susceptible to inhibitors of microtubule function. We will talk about these drugs more in the next two lectures, and you will see some of them are cell specific or non-cell specific. Now, slow-growing tumor, for example, colorectal cancer أو non-small non-small cell lung cancer, are considered slow-growing. So their treatment or to chemotherapy or response to cell cycle specific therapy are less than the faster growing tumors. But that does not mean the protocol of these tumor does not include the cell cycle specific drug. For some يعني these cell cycle specific therapy are still used in these tumors. However, you don't expect مثلا success rate to be as high as in, for example, small cell lung carcinoma. And small cell lung carcinoma is faster growing than the non-small cell lung carcinoma, for example. Now we have also the non-specific drug, which kill both cells at G0 or cells that have arrested growth and the cycling cells. However, even the non-specific cell cycle, non-specific chemotherapy, يعني they work better على على cycling cells. Okay. So tumor growth, البروفيليشن تبعته, الريت تبعته really affect ال predictability of how this treatment will work. Okay, so we have this an idea of how chemotherapy kills the chemotherapy cycles kills the or cure the tumor. So destruction of cancer cell by chemotherapeutic agent follows what we called a first order kinetic or log kill model. So in this model, tumor cells, okay, هذا هو tumor cells over time الجروث تبعهم. هاي عدد السيلز، عدد tumor cells وهاي التايم. And so this here هنا الجراف هون هذا بيمثل التيومر cells growth over time هنا without any intervention. Okay, so what they noticed is that, or this model what suggests that the tumor cell will for example double in size, triple in size in a constant rate. So for example مثلا نحكي كل أسبوعين مثلا it will double in size the tumor cells. Okay, أو it will triple in size every 3 weeks. So it's الموديل هذا شو بيحكي there is يعني إذا if you give a chemotherapy, a given dose of a drug destroy a constant fraction of cells. So if you start يعني نحكي انت بلشت ب 100 cells طبعا بالtumor it's way more than that بس لنحكي 100 cells the first cycle of chemotherapy will kill 50 نحكي 50% it will kill 50%. So half of the cells will die. So شو انت left ب 25 ب 50 cells. Okay, هذول ال 50 cells you give another cycle of chemotherapy نفس الدوز. This will kill 25 كمان مرة 50% من هذا ال 50 فأنت يبقى عندك 25 cells. So what we're saying here يعني إنه ما it doesn't يعني شو الفرق يعني مثلا أنت لما تحكي log kill model أنت بتحكي عن percentage of this of the rate صح of the whatever left من cells. It's not like they will هذا الكيموثيرابي بيقتل كل مرة مثلا نحكي مليون سيل. No, it doesn't work like that. It doesn't يعني ما بنقدر نحكي إنه هو بقتل مليون سيل. لا إحنا بنحكي إنه percentage من السيلز اللي ضلت. This is what it means by a constant fraction of cells. So if you noticed here لما إذا هو it left يعني ال tumor cells keep growing until patient dies. Okay, Now, if you see here, for example, in the curative chemotherapy, you will give this. So remember that chemotherapy is very toxic, and فأنت ما بتقدر تعطي الكيموثيرابي مرة واحدة بدوز عالية مرة واحدة. No, you have to have cycles. يعني you give a dose، تستنى على المريض حسب البروتوكول، يعني مثلا نحكي أسبوعين عشان الهيلثي سيلز regain function، شوي يرتاحوا. بهذا الوقت التيومر it will increase in size as well. ما رح يرجع على نفس الحجم الأول، بس it will be growth. And this is why you see هذا zigzag. It's not a linear like this. It's a zigzag لأنه الكيموثيرابي is giving in cycles. يعني تعطي you stop، تعطي فترة، تعطي يعني وقت راحة، بعدين تعطي السايكل مرة ثانية. And you can see here every time it kills the same fraction, okay, until cure happens, okay, until most of the cell, most of cancer cell is killed. في احنا رح نحكي عن how is chemotherapy is giving. This is palliative chemotherapy. Palliative يعني انت you want to ease symptoms when you give a cycle of chemotherapy. However, it will not kill, eventually it will not be able to kill all the tumor. بس السايز تبع التيومر will decrease، البردن رح decrease, but however it's eventually lead to death. So this is what is called, and you see here, for example, surgery, you reduce the burden of أو عدد السيلز يعني بشكل كبير. So and then you give chemotherapy cycles, and here with the surgery, you know, you decrease the doses والcycles of chemotherapy، لأنك أنت كثير بتقلل البردن تبع أو عدد الخلايا الكانسر قبل ما تبلش بالكيموثيرابي. However, this log-kill model is not very representative to what's happening in the real life. إحنا حكينا خصوصا لأنه هو هذا الموديل كان اللي اكتشفه يعني أو اللي suggested for the first time it was على in vitro leukemia cells, which okay shows these constant fraction over time. However, إذا أنت you want to translate this into الحقيقة into reality, remember إنه مثل ما حكينا مثلا خصوصا بالsolid tumor مش بالهيماتولوجيكال tumor, especially بالsolid tumor هذا أول إشي التيومر will be يعني رح حكينا إنه السايز تبعه بسرعة أو الريبليكيشن تبعه الجروث تبعه بيكون كثير سريع، بعدين شوي شوي ببطأ. فلما احنا حكينا انه الكيموثيرابي بيعتمد على قديش السيلز are replicating او how fast the more the faster the growth the more sensitive to chemotherapy. So this model has its يعني هاي، وفي اقتراحات لموديل ثانية more representative، بس صراحة ما راح نحكي عنه لأنه يعني into second year and I don't think you need to know all of this، بس at least know إنه it doesn't kill مثلا يعني الكيموثيرابي احنا ما بنحكي بقتل 100 مليون سيل بكل جرعة، لا احنا بنحكي مثلا بيقتل 50% بالجرعة الأولى، أو it's a constant fraction, or at least the log-kill model like this. So for example, diagnosis of leukemia is made at لما يكون عدد leukemic cells 10 قوة 9 cell. Okay, so 10 و9 أصفار يعني 1 و9 أصفار. So 1000 million. لما يصير عندنا 1000 million leukemic cells هنا تبدأ الممكن إنه it can be diagnosed leukemia. Let's say the treatment result in 99.999% killings. So لما أنت تعطي the first cycles, how much is remaining is 0.001%. That means 10,000 cells. You can do the math. يعني أنت you can do the math yourself. Okay, فتبقى 10,000. This is what this is equal to log kill 5 أو 100,000 fold reduction. Okay, so if you يعني أنت قللت من 10.09 ل 10.04. So how much did the difference؟ تعرف لما نقسم 10 قوة 9 على 10 قوة 4 الأسس تتنقص، so 9 ناقص 4 5، so الباقي هو 10 قوة 5. This is what's called the log Cal5. Another time when you give البيشنت هذا 10.04 another cycle راح ينقتل منه كمان يعني remains will be by يعني بتتنقص by 5 and this is what we call this is equal to log 5. Okay, meet-fold reduction. Now until يعني it's you give the chemotherapy and until لما يصير إلى أن يصير عندنا a state of asymptomatic أو remission. في هاي الحالة حكينا إحنا إنه sometimes شو بصير إنه يعني you're not sure إذا 100% انقتلت، في راح يكون يصير يعني حجم التيومر كثير قليل أو عدد اللي بنسميه إحنا الكانسر بيردن قليل، بنسميه إحنا remission إنه ما في symptoms، بس بضل إنه فرصة إنه هذولا whatever remains من الكانسر will grow again and يصير عندنا relapse بالcancer therapy. So this is why additional treatments are required. Now you need to have يعني a really reduced number of يعني almost zero number of cancer cells, which is different من antibiotic. How so? Why is that? Remember, antibiotic, you're fighting bacteria, so it's easy for the body to recognize إنه it's bacteria والimmunotherapy والimmune system تبعك fight these bacteria or viruses, these foreign bodies. So what happens with the antibiotic أو مثل anti viral especially in antibiotics, the aim of antibiotic you want to reduce the burden of these bacteria عشان اللي ما يتبقى منها it will be resolved by the immune system. So you help in the reduced number of bacteria عشان you help the immune system get rid of the rest. However, بالcancer cells احنا حكينا انه it can evade immune response and remember even though there is accumulation of mutation, they are still human cells. So it's even more difficult for the immune system to recognize these cancer cells. So this is why in immune system يعني does not really help. يعني you need to really reduce the number of cells because you cannot rely on the immune system alone to يعني get rid of the rest of the cells. So the goals of chemotherapy when المريض لما الدكتور يعطي المريض chemotherapy in his mind حسب الكيس there are different goals حسب الكيس الحجم الحالة تبعت المريض whether it's advanced metastasized الحجم. So it's either أو حتى نوع genetic makeup of it's all يعني هذا الأسسمنت يعني الجول تبع الكيموثيرابي will differ from type to type, from patient to patient. So the first goal is to cure. This is the ideal ultimate. You want to cure يعني cure cure the disease, and this means long-term disease-free survival. يعني مثلا بعد 5 سنين ما كان في again relapse or remission of the disease. This is called okay. Then we probably say okay, probably it's يعني حتى تعتمد حسب التيون نحكي إنه okay, the patient now is cured. So to do that, you need to eradicate every neoplastic cells حتى ما ترجع يعني يصير لها replication مرة ثانية. The second goal is to control the disease, and in this يعني in this sense it's you بحكي لك تعامل مع الكانسر as if it was a chronic disease. So what you want is to يعني get remissions and prolong remission. So the patient will almost have a normal life. Okay. You want to prevent the tumor growth and spreading. Um, uh, a lot of drugs يعني can be used for years as to control cancer. مثل البارب inhibitors they could be used يعني 3 years وحتى في doctors indefinitely حسب الاسسمنت تبع يعني they really use it for really long time these chemotherapy or anti-cancer agent with a chemotherapy or other modalities عشان to control to prevent this growth and to prevent the spreading of the disease. But you know there's probably tumor cells around. So if they stop treatment, probably there's a high probability the tumor will come back again. The third goal is palliation. When you hear palliative care, you mean you want to control the symptoms, relieve is symptoms. So many of these cancer patients will have devastating symptoms that will affect really their quality of life. Let's say colorectal cancer. You have a mass in the intestinal or بالمريض. فإت can this mass can block the intestine. Patient ما راح يقدر مثلا راح يعني it will يصير انتفاخات ويصير انه ما في nutrient passage through these intestines will be affected, so it's really devastating. يعني يعيش بهذه الحالة. وغير انه مثلا الكانسر may cause هذا a lot of cancer cause fatigue, pain. So these distress symptoms, for a lot of cancers that they're not curable, or for example, the doctor cannot resect the tumors. The doctor can use chemotherapy عشان reduce the size or help in reducing symptoms. Okay, for example, in advanced non-resectable colorectal cancer, chemotherapy can be used to shrink the tumor, for example, to alleviate البلوكage أو شوي النيوترينت يصير لها absorption أحسن أو alleviate the distress symptoms the patient feels. Now, the treatment protocol عادة chemotherapy are given in combination يعني more than one chemotherapy يعني given at the same time. Now, the selection of this combination, these agents, they should have different mechanism of action and different toxicity. So why they should have different mechanism of action عشان يكون effective تكون تبعهم يعني يكونوا effective أكثر لأنهم إحنا حكينا التيومرز they develop more than one pathway goes wrong. فإف you يعني سويت أنت targeted more than one pathway probably الافيكاسي تبعت التريتمنت تكون أعلى، بالإضافة عشان تقلل من ال chance of resistance. Different toxicities, a lot of we will see toxicity of chemotherapy. A lot of these drugs will have a very devastating and يعني lethal toxicity. For example الميلosuppression اللي هو suppression of the bone marrow. And if you have two drugs, combining two drugs with the same toxicity, then you have synergistic effect of this toxicity, and this will put the patient in dangers, okay? Now, combination therapy are more successful than monotherapy, يعني in using a single drug, because it maximizes cell killing. It's effective against a broader range of cell lines in heterogeneous tumor. So remember that we said about the tumors, they have different cells. And الفكرة بالtumors والمزعج بالtumors إنه these cells, they don't have the same genetic makeup. They will have different mutation. So if you have more than one drug, acting differently, probably it will affect more than يعني one cell line of the tumor. And also it will also help in delaying the resistance. Now, resistance against chemotherapy, this is a fundamental challenge. يعني هي مشكلة بالchemotherapy, and this is why a lot of chemotherapy يعني fails وفي عندنا relapse للdisease. Probably انتوا اخذتوها، ما بعرف اذا اخذتوها ولا لا. It's resistance types either inherent او acquired. Inherent يعني هو هذا الكانسر is not working against this، هو من اول. بدون ما يعني without the prior exposure of the drug. For example, triple negative breast cancer is very annoying يعني cancer. There is يعني only few drugs can work on it because it lacks a lot of the pathways or targets that a conventional chemotherapy will work on, as well as so this is the cancer. Even without the exposure, it will, even with the first exposure, it's not gonna kill any of these cells because they lack the target that these chemotherapy are targeting. The acquired one is after administration of the drug, even sometimes even after administration of one dose. The mechanism is diverse, okay? So you probably are familiar with the efflux pump. It's and the efflux pump is usually associated with multi-drug resistance. So what happens, there's overexpression of this efflux pump, and so the drug enters the cells, and then this pumps, what happens يعني using ATP, it will excrete drugs outside the cells. And many drugs are susceptible to this efflux pump, and this is why we called it's associated with multi-drug resistance. Some of these يعني mutation are related or specific to the anti-neoplastic agent. For example, some of these cells will increase the metabolism. For example, increase the expression of the cytochrome enzyme CYP450, and increase the metabolism of the chemotherapy. Or, for example, it will, if certain drugs target a certain مثلا receptors or a pathway, it will increase أو يصير عندنا overexpression of this target بحيث الكيموثيرابي dose هذا is not enough to overcome يعني يعني affect all these targets. أو إنه نفس الباثواي اللي the anti-neoplastic agent is targeting خلاص السيل كانسر يعني بطريقة ما قدرت إنه يعني حتى لو صار له تثبيط مثلا it's another pathways develop another pathways بحيث ما بتحتاجه. So this is what we call about bypass target. Okay. أو مثلا alter drug target فما بصير عندنا binding أو مو موجود أصلا عشان الدرug يأثر عليه. Now, chemotherapy administration in the clinic is either as adjuvant treatment, it's given as adjuvant treatment, which means it's given after surgery or radiotherapy to attack micrometastasis and reduce recurrence rate. So in this, يعني remember surgery or radiotherapy يعتبروا local management, local treatment management. الكيموثيرابي لا، يعتبر إنه systemic. فالسيستميك it means يعني it go through all the body. Local إنك مثلا surgery خلاص أنت you remove this tumor from this site. You don't know, you can't influence, for example, the tumor cells that مثلا went through the bloodstream into another site, or عشان مثلا يصير لهم metastasis. أو مثلا ممكن sometimes هاي micrometastasis those tumor cells will infiltrate in the surrounding tissues. فممكن السيرجري ما ياخذها كلها هاي التيشوز. You need something systemic that will go everywhere and will reach all these small metastases. Okay, so this the goal is to reduce rate of recurrence. Neoadjuvant treatment is when السيرجري surgeon مثلا they can't do surgery because the tumor is too big, okay, أو إنه يعني not accessible. Sometimes they need to reduce the size of the tumor before going into surgery or radiation. You give chemotherapy before surgery, and this is what we call neoadjuvant treatment. The other treatments يعني how they administer drug اللي هو maintenance. So a lower dose of the chemotherapy is given. This is when we talked about treating the cancer as a chronic disease. Is given to prolong the يعني to assist in prolonging remission. Again, PARP inhibitors, kind of targeted therapies, are given in advanced ovarian cancer after complete or partial response to chemotherapy. So يعني هذول patient they have chemotherapy treatment, وبعدين خلينا نحكي بعد آخر cycle they give a low dose of PARP inhibitors حتى reduce إنه يرجع إنه يرجع الديزيز مرة ثانية، أو الفترة من إنه يرجع يعني طولوا الفترة من إنه يرجع delay remission time. So the anti-neoplastic chemotherapy, we said they're cytotoxic. They have a narrow therapeutic index. They are toxic. So normal cells with rapid proliferation are more prone to cytotoxic effects. For example, the buccal mucosa, the bone marrow, the gastrointestinal mucosa, the hair follicle. They are يعتبروا fast growing, and they are more susceptible to chemotherapy. The effect of these side effects could be reversible, مثل alopecia, but not all alopecia reversible, but sometimes it's reversible or irreversible, for example, cardiac or pulmonary toxicities. These include severe vomiting, stomatitis, اللي هي stomatitis, inflammation of mouth tissues. Bone marrow suppression is very important, and the myelosuppression, it's make the patient more prone to infection, and it's a lot of drugs can cause myelosuppression. Alopecia اللي هي losing of hair. Tumor lysis syndrome. So sometimes, especially if you give the patient the high proliferative rate or sensitive أو tumors مثل الليمفوما, what happens is when you give the chemotherapy, a lot of the cells, a lot of tumor cells will be killed at the same time, but they release their toxins or their component, the dead cell would release their toxin into the bloodstreams. These toxins, for example, nucleic acid. النيوكليك اسيد بتتكون من تذكروا من فوسفور جروب من وشجر ونيتروجين بيس. هاي النيتروجين بيس اللي هو الادينين، الجوانين، الثايرونين، all ثايمين. هذول النيتروجين بيس لما يروحوا على البلاد ستريم their metabolism will يعني في النهاية يصيروا زانثين hypoxanthine. في النهاية eventually they will be يعني metabolized into uric acid. it can cause increased uric acid. Remember the potassium inside the cell is higher, يعني higher concentration of potassium inside the cell also will be released into the bloodstream because hyperkalemia, increased potassium, this may يعني affect for example الهارت ويصير عندنا arrhythmias. Also as well الphosphorus group again من النيوكليك acid. Now, these phosphorus group, what happens is that they will attach circulation مع الكالسيوم فيصير عندنا hypocalcemia أو low calcium, and these phosphorus calcium تصير عندنا مثل السولت. they can يعني يترسبوا بالtissues, for example in the heart, it causes different أو بالrenal tissues, it causes for example arrhythmias and renal أو this is tumor lysis syndrome is an oncology يعتبروها oncology emergency, so you treat it in the emergency room. Also هذول الكيموثيرابي a lot of them they will work على ال DNA والreplication it can cause secondary malignancy, for example acute myeloid leukemia, which is really hard to treat. And sometimes there some adverse effect will be يعني تعتمد على الدرug itself, for example bladder toxicity, cardiotoxicity, and some of these drugs will cause pulmonary fibrosis. Now next week we will talk about the chemotherapeutic classification, and I put this slide لأنه لما تفتح أنت يعني you want to read عن how these chemotherapeutics are classified. There are a lot of طرق حتى you classify them, either على if they are cell specific or non-cell specific, either على mechanism of action, either على biochemical structures. different source will have different يعني شوية اختلاف ب how they classify the drugs, and some drugs will act in more than one way, so they may belong in more than one group. And next week we will start with the chemotherapy, cytotoxic chemotherapy, for the next 2 lectures, and then lecture الأخيرة راح تكون عن targeted therapy. Okay, that's us. واللي عنده أي سؤال ابعثوا لي على التيمز بأي وقت تشعروا أنكم بدكم هذا سؤال عادي ابعثوا على التيمز. ويعطيكم العافية.